carbohydrate pool. Glucose, monosaccharide, sugar. You're sweeter than a woman's kiss, 'cause I need you for glycolysis. I just can't believe the way my muscles take you in.
For you, they'll open the door.
All it takes is a little bit of insulin
To upregulate glucose.
Oh, glucose. Oh, sugar, sugar. You help me make ATP when my predators are chasing me. Oh, glucose. You're an aldehyde sugar, and you're sweeter than a woman's kiss, 'cause I need you for glycolysis. I just can't believe the way my muscles break you
My
down.
glycogen is almost gone.
A few more seconds and I'll be rigor mortis bound.
Acidosis done me wrong.
Your sweet is turning sour, baby. I'm losing all my power, baby.
I'm gonna make your muscles ache.
No, 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 I'm swimming in lactate, babe. Oh yeah, I'm swimming in lactate, baby. Now I'm drowning in lactate, baby.
I'm gonna make your muscles ache.
No, 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 I'm swimming in lactate, baby. Oh, glucose. Oh, sugar, sugar. I used you up and you left me flat. Now I'll have to get my kicks from fat. Oh, glucose.
Glucose, sugar, sugar,
Sugar, sugar.
glucose, sugar,
The
sugar.
honeymoon is over now. The honeymoon is over now.
Test, test. Afternoon. Welcome back to Grand Rounds. Please remember to fill out the attendance record, and also please remember to fill out the program evaluation, and we're always interested in future topics or future speakers that you might be interested in hearing. Today, it's my pleasure to introduce Dr. Rick Carano. Dr. Carano is board certified in internal medicine and endocrinology. He comprises 50% of the endocrinology department at the McFarland Clinic, and he's kindly accepted our invitation today to discuss insulin pump therapy. Please join me in welcoming Dr. Carano.
Thank you, Steve. Thank you all for coming. For those of you who thought pumping up was an anabolic steroid talk, I'm sorry, but it's about insulin pumps. And the song you heard by the Archies was, I think, sung by my partner, Dr. Al-Makayad, but, oh, there he is. There he is. The words were made by Barb, though, in all the diabetic education. So today's presentation is about pumping up with insulin pumps. As you'll see in this presentation, it's become a large component of care for type 1, especially type 1 diabetics. And therefore, we're going to be seeing a lot more of these patients in your clinics and in the hospital. So we thought it would be a good idea if you had a better idea of what insulin pumps are, why they're popular, and how to at least get an idea of some of the features of a pump and how to even maybe touch a pump and push the buttons on a pump and get a feeling for how to use a pump, especially the nurses and the doctors that are here. So we actually, at the second part of the presentation, which will be by the nurse educators, are going to be having hands-on opportunity to actually work with the pumps. So we're excited about that. I hope you are too. So the objectives today are to discuss basic concepts involved in insulin pump therapy, to identify considerations in managing a hospitalized patient who's receiving an insulin pump and using an insulin pump, and to just understand basic button pushing on the insulin pumps to kind of be able to retrieve information from the pump and possibly even learn how to give bolus and adjust some of the basal insulin dosing rates. Although we have June here for any of those more difficult cases. How are we doing with diabetic care? It's still an ongoing, difficult disease. It's a chronic disease that affects millions of Americans, and the management is difficult. No one's going to deny that. We try as physicians and caregivers to do our best to give our patients the best care, but a lot of the final outcomes are patient-driven. And so as a result, we have a lot of factors that influence the control, and then we don't get the numbers that we want. As you can see from this slide, the average hemoglobin A1C, which is the test we use to get an assessment of how well we're doing with glucose control, in the US, diabetics is 8.6%. That's all comers, and that's over a third of them exceed 8%. And actually, I think it's over 2/3. I think that's a typo. Poor hemoglobin A1C awareness also. Patients, if you ask them whether their hemoglobin A1C, a lot of them will not have any idea. They'll be clueless. And 81% of them surveyed believe that their diabetes is in good control, but only a fifth of them report their A1C levels below 7%, and that's the goal. The goal for most diabetics is to have that A1C below 7%. So you can see that there's a misconception of how well they're doing with their diabetes. And when you look at type 1 diabetics, about 30% of them are still using conventional management for their diabetes. And I'll get into more of what that means when we look at the DCCT studies that are part of the presentation. But in a nutshell, conventional management is, a couple of insulin injections a day, sporadic monitoring of blood sugars. And that has been shown not to be effective. And therefore, ever since the DCC was completed in the mid-1990s, there's been a push for more intensive management of diabetes, either with multiple daily dosed insulin regimens or with pumps, which we're going to talk about a lot today. There's a lack of awareness, reimbursement, and treatment standards contribute to poor diabetes control. And these are all, again, driven by our society, by our insurance carriers, by the government, and by patients, and also by caregivers. The ADA goals for glycemic control are listed here. It does vary in different age groups. If you're a preschooler, before school age, which we do not deal with much at this facility. Most of that care is with pediatric endocrinology, but their goals are different than adults. You can see that the A1C is between 7.5 and 8.5, mainly for safety and avoiding hypoglycemia in that age group, and the brain development, how important it is not to get hypoglycemic issues. So their pre-meal blood sugar goal is between 100 and 180, and at bedtime, overnight, actually up to 200. But as we age and we get more able to help care for our diabetes, in the school age group, the A1C is 7.5 to 8% goal. Preprandial is more in the 90 to 180, and overnight 100 to 180. And then as adolescents, difficult time for people to deal with this disease. Our goals are even more aggressive. A1C is less than 7.5%. Pre-meal blood sugar is 90 to 130, through the night 90 to 150. And in the adults, the A1C goal of less than 7%. In most, not in the middle age to 70-year-old individual, probably more 6.5% goal. As they get older, we tend to loosen up on those goals, but in your adult population, most of them we want less than 7%, with the pre-meal values of 90 to 130, and their post-eating peak value of less than 180. Poor control remains a problem. Now, as we just alluded to earlier on, 2/3 of patients with diabetes, including pump patients, are not in what's considered to be goals of therapy. The goal is listed right here. We talked about that 6.5 to 7% goal, and here's where our patients are. The average type 1 diabetic is up above 9%, and the average unpumped is about 8.6, 8.7%. So we're not getting there yet. And why is that important? Well, the huge study that went on for several years and was completed in the mid-1990s, called the Diabetic Control and Complication Trial, is shown here in one graphic presentation of why we're so concerned about high blood sugars and high A1C values. As you can see, it's more of a logarithmic increase in complications, especially with eye and kidney disease, as their A1C goes up. So if you look at that goal blood sugars of A1Cs of 6.5 to 7%, you can see very minimal increase compared to baseline non-diabetics of complications. But as you come up to 8, 9, 10, 11, 12%, especially these two categories of ophthalmologic complications and kidney disease, just take off like a rocket ship. And you can see that you're up to 15 times likely to have these complications in a diabetic that has A1Cs in that 11, 12, or greater percentage. Usually it's the second decade of diabetic, poorly controlled diabetes where you start seeing these complications. You're kind of somewhat insulated from these complications in the first decade. But as you get into the second and third decade, it really takes off. Good question. And again, any questions, please just, like Dr. Berryhill did, just raise your hand and I'll try to catch you, okay? Another way to look at this in the DCCT is how much did we reduce those complications? Now you saw how great the complications were. What happens if you get better control? And in the DCCT, they didn't have great pump therapy. They didn't have great MDI programs, multiple daily dosed insulin regimens, because they didn't have the insulins that we have today. They randomized patients into an intensive regimen, which was pumps with regular insulin. It was buffered regular insulin. Or with multiple shot programs using NPH and regular insulin versus standard care, which is NPH and regular breakfast and supper. So your conventional standard care against the intensive care. And here's what happened. In those that were intensively treated, and in the intensively treated group, they also had more follow-up with dietitians, diabetic educators, and with their physician. So there was more follow-up and care for those patients than in the conventional group. And you can see it was pretty impressive in the reduction of complications during that study of about 12 to 15 years. It was 76% reduction of retinal progression, retinal disease in that group, and risk reduction of almost 60% in needing laser treatment, about a 40% reduction in microalbuminuria, which is a marker for early renal kidney disease from the diabetes, and a reduction of 54% in actual albuminuria, which is more advanced kidney disease, and a good 64% reduction of clinical neuropathy, the painful peripheral, your feet and hands, and especially the feet pain and lack of sensation and numbness and tingling and sores, and increased risk of diabetic foot ulcers. Significantly increased. These results from the DCCT then took off and it precipitated the need for improving control in the diabetics. These are in type 1 diabetics, but in all diabetics. But this study was done in type 1 diabetics. But it kind of took off from there in the mid-1990s, and that's why we've seen so much more intensified treatment with multiple shot programs and with pump therapy. And here's where the pumps started. These were before the DCCT, but not long before the DCCT was started. This is kind of like the Rocket Man, where you can see that the first pumps, when they were first being developed, were huge, and they were quite a device to carry around. And as we've advanced along with this device, it's become much more compact, and you'll see when you do the hands-on presentation how nice and compact the devices are. The origins, the first insulin pumps actually appeared in the late 1970s, and they were large portable chemotherapy pumps that were used, and they were converted from chemotherapy machines to deliver insulin instead. And you had to be, of course, in hospital for that to be done. So it was more of an investigational research tool. They found that it was useful, so they proceeded to try to develop machines that were more portable. Here's one of the first ones. It's the auto syringe ACE S2C and Harvard apparatus, Mill Hill infusers. So these were all early, fairly large type of pumps that used large 50 ml syringes. Now our syringes now are 3 ml. So these are big 50 ml syringes, and they diluted the insulin so that it was U36 or U18 instead of the U100 that we use today. And they only had one basal rate, so in other words, it just infused one rate. You couldn't adjust the rate. No memory, so you couldn't go back and see what you'd done. So it was pretty archaic. Here's the biostator up here. This is the one we talked about that they converted from chemotherapy. And here's that AS2C device here. And here's kind of more of what we're dealing with today. Insulin pump usage in the U.S. has really taken off. Here's a good example of what I mean by that. You look back to the mid-1990s when the DCCT was just being reported, and we were seeing the significant benefit of good control of blood glucose levels. From there, when we were into 20,000 people in the U.S. on pumps, over the next 15 years, we're up to 300,000 and climbing. I'm sure 2012 we're much higher than that, because it's become a very common, pretty much standard recommendation for especially type 1 diabetics that are capable of using these devices. Who are the candidates for pumps? Initially, when in the evolution of pump applications in the 1980s and early 1990s, it was a very select group. They were still a new device, a lot of kinks to be worked out with them. The risk benefits needed to be considered, but at least early on, the groups that were felt to be candidates were very few. It was people with severe hypoglycemia and hypoglycemic unawareness, severe dawn phenomenon. That's when the patient is waking up and there's this huge elevation of blood sugar in the morning hours. Pregnancy then became an indication. Preconception for pregnancy became an indication. And then it was found that maybe these people that had shift jobs, that were having a change of their schedule from week to week, got benefit. And then maybe gastroparesis, these people that had the complication of delayed gastric emptying would benefit from a pump compared to standard treatment. Severe hypoglycemia continued to be an indication. And then athletes, pediatric patients, type 2 diabetics even became candidates. The group continued to enlarge, and now current applications are if you have diabetes. Okay, if you have diabetes, you're a candidate. Especially if you need to normalize blood sugar, A1C 6.5, as I showed you on the first few slides, we're far from that in most of our patients. So a huge number are qualifying just for the fact that they're diabetics, they're out of control. They have a lot of excursions of their blood sugars, and we see that in many patients. And if they're having hypoglycemia, or it's just their lifestyle, like their shift jobs, or a need for more flexible insulin program. So you can see the majority of patients are probably candidates for pumps. It's whether or not they want a pump, and whether or not we can get approval from an insurance carrier. That's another big component of it. So from the standpoint of what we look at also, besides just what their numbers are they willing to monitor and record blood sugars a minimum of 4 times a day? Because otherwise a pump's not going to be that beneficial if they don't do the things necessary for it to be effective. So they need to be willing to check their blood sugars. They need to take their insulin. The pump will not administer the insulin without being told what to do. So they have to push the buttons. They have to be willing to test their blood sugars, dose their insulin based on what their blood sugar value is at the meal time and what they're going to eat, because they also need to be willing to match up the insulin with their carb counting technique. So that's where our team here of dietitians and diabetic educators comes in. It's very important that if we're going to achieve the goals of therapy that we're striving to do, they need to know how to carb count, check their blood sugars, know how to troubleshoot highs and lows, and keep up to date on the features, new features, advanced features, and Barbara talked to you more about this, of these pumps, which are remarkable devices that really allow patients to have a great opportunity to maintain control of their diabetes at those goals. This is a normal profile of what insulin does. You know, you have your basal background insulin and in here, and then when you eat, there's these peaks of insulin release. So we try to mimic that, okay? So we have that, I told you in the DCCT, they used the multiple daily dose insulin regimen, and in this situation, example here, they used NPH and regular, and they gave both an NPH and regular dose here, trying to cover that breakfast and lunch with that treatment. It works fair but not great, and then regular again at lunch, to try to cover that elevation and to cover here the mealtime carbohydrate intake at supper, and then the NPH through the night. Now nowadays we tend to use more Lantus or Levemir, which are the basal insulins that have the release of 24-hour action, and we use Humalog, Novolog, or Apidra, which are the fast-acting insulins that take the place of regular in most of our patients. And that's the multiple daily dose insulin regimen. With pump therapy, similar idea. You have your basal insulin dose, where you use just rapid-acting insulin therapy in pumps, either the Humalog, Novolog, or Apidra, which are the 3 rapid-acting insulins. In majority of patients, we use a rapid-acting insulin. We use a basal dosing, which is a background insulin, basically, and then we cover the meals with boluses based on that important carbohydrate intake and blood sugar monitoring. So it's so important that they do all these things for this to be an effective program. Yes, ma'am. Yes, you would not have any basal long-acting insulin. You won't need Lantus or Levemir or NPH insulin. It's all done with rapid-acting insulin. There's a continuous slow release, very low levels of basal insulin with the rapid-acting insulin, and then there's boluses for the meals, the snacks, or for the elevated blood sugars. It's a very good question. Once we get a pump, we don't need the basal insulin. They usually, when they have renal failure, we usually have a lower requirement of insulin. And then, we'll go through how we calculate dosage on here. Okay? So you got a diabetic. Hey, here's a nice athletic soccer player. And how do we calculate? Well, when we are converting a patient from the regular program of Lantus and Humalog, for instance, and converting them to pump therapy, we calculate their total daily dosed insulin, and we give 75% of that. We always start a little on the lower end to avoid hypoglycemia. Pump therapy seems to be a little more effective than subcutaneous injections. So we tend to be a little cautious. We modestly reduce the total daily dose to about 75%, and then we ration that out initially 50-50, 50% basal and 50% bolus. We use the insulin to carbohydrate ratio. Again, if it's a new diabetic, rarely are we starting them right off on a pump, but if we do, we tend to use about a 0.6, 0.7 per kilogram as a dosing of how much total daily dose insulin they need, and we divide out from there. But in patients that are already a diabetic, which is 99% of the patients that we start pumps on, that's already on insulin, we tend to use what they've been doing, take 50%, take the total daily dose of insulin, TDD, the rule of 500, take 500 divided by the total daily dose. Let's say that they're taking 50 units as their total daily dose. These are nice and easy ones for us mathematicians here. You get 10. So the insulin to carbohydrate ratio is 10. So for every 10 grams of carbohydrate, you take a unit. Okay? That's the rule of 500. Pretty simple. Now we have another rule. We have, we're not always going to have them right where they want to be. They're going to have a pre-meal blood sugar of 190. We got to do something about that high blood sugar, so we have this insulin sensitivity factor. Correction factor is another way to look at it. And in people on Humalog, Novolog, or Apidra, the rapid-acting insulin analogs, which most of them are, we use the rule of 1800. Better have your calculator, because you take 1800 divided by the total daily dose, and that tells you how many milligram per deciliter drop you're going to get for a unit of insulin. So the example is, let's say you got 100 units is their total daily dose for every. So you divide 1,800 by total daily dose of 100. It's 18. Okay. So it'd be 18. Would be how much you'd expect it to drop with every unit. Okay. And then there's a rule of 1,500 that we don't tend to use as much anymore because we use less regular insulin. So I'd like to field more questions now, if you have any, about just some of the issues that you had raised there. Because we're getting into where we're going to have you actually have hands-on experience with these devices. The pump, it's a pump, has a reservoir. It's similar to a syringe. Remember I told you that most of our syringes hold 3 ml of insulin, which is 300 units. That's the standard amount. That's usually 2 to 3 days worth of insulin for most patients. Okay? It's a small computerized battery operated device. It allows the user to know, to control how much insulin is being delivered, and you'll see how that's done. There's a plastic tubing with most of these devices, and do we have any of the pods? Okay. They'll go over some of the other devices, but most of these have plastic tubing. There's a cannula that's inserted right underneath the skin, usually use the abdominal area, the buttocks, sometimes the upper arm and the thighs. And if you have questions about that, the educators can kind of go through that with you. But there are a variety of different areas that we use for the infusions. The infusion catheter is very painless to put in. It goes underneath the skin and subcutaneous tissue. It usually stays there for about 3 days, and then we ask them to change it. The insulin passes from the pump reservoir, where the insulin is, through the tubing into the cannula, located in subcutaneous tissue of the body. And that's how we get it there. We offer the latest technology for precise insulin therapy, and benefits include more flexibility, less hypoglycemia, and that's been shown to be, statistically true, less glucose exposure. Like I told you, we tend to have to use less, we tend to get better control of the blood sugars, so you have less hyperglycemia, healthier life, less complications. But it requires commitment, responsibility. The patient has to be on board. Yeah, they have to be really committed to making these necessary lifestyle changes to be a good pump patient. Training, follow-up, they're very necessary. You can't just give them a pump with one visit and say, good luck, read the book. They need guidance. They need support. They need a team. They really do. And they need to make a commitment to their health, and then they start pumping, and in general, they do well. So we're here to pump you up, and so are Hans and Franz. Can you get that going? All right, so let's get pumping. Okay, the bar fact is going to give you a little bit more information and then have the hands-on demonstration. Thank you.
Can you hear me now? Okay. Anyway, we don't expect you to be experts, but we do want to give you some tools so that you can work with this growing number of individuals that you're going to be seeing that are on insulin pumps. There is going to be more patients coming into the office, more patients coming into the hospital that are going to require support and assistance with their insulin pumps. And we want you to know what to do and where you need to go to get help with that. The individuals starting on an insulin pump usually get 7 to 10 hours of education when they're starting on that, and this is followed with daily, which gradually moves into weekly phone calls from the educators. We are constantly in contact with them as they learn to make adjustments on their pump, and we also follow them closely while they're learning to make adjustments based on their blood glucose patterns. There's no way that in 1 hour we can explain all of that to you. But if you have questions after we're finished and want to come down and ask us, that would be great. Or if we're not able to have time for that today and you'd like to call us at another time, we'd be happy to answer your questions or give you more instructions. I would also like to add, when we put up the slide that Dr. Carano used on hemoglobin A1C, it shows that the national average of people on insulin pumps is about an 8.6. I did calculate what our average is in the Diabetes Center, and in the past year it is running well below the national average. We were at 7.6 until yesterday. Not a good day. But when we see people coming in and they have the appropriate support, we do find that they do much better. We have an outstanding team that we work with in the Diabetes and Nutrition Education Center, a fun group that's good to work with, and a good resource for any of you. I'd like to introduce them. They're all certified diabetes educators, and between us we have 65 years of experience. And I want to introduce June Hayden. She is a nurse, and she's our inpatient or diabetes resource nurse for inpatient care. So if you have any questions, call June in the hospital. Mindy Cardell is another nurse educator and has been in the Diabetes Center for 9 years, and is a nurse educator. Did I say that? And she's, okay. And Lynn Maves is a dietitian with the Diabetes Center, and has been there 9 years. Okay. And Sarah Havman is another dietitian in the Diabetes Center. And like I said, all of them are certified diabetes educators. And I'm just really proud to work with these group of women. And like I said, if you have any questions, please feel free to call them. The other people that I want to recognize are our director, Jane Jackson, and she gives us lots of encouragement. And also Jana Hagan is a new person with the department. She's a AmeriCorps member, and she is focusing on childhood obesity, and I'm doing some work with adult obesity. We're hoping to get something started here at Mary Greeley. And they will both be at the doors to greet you as you leave, because we don't want any of the insulin pumps walking out accidentally. We have about $100,000 worth of pumps here, and we need to return those. Okay, getting started with the tools. First you have the resources, and we have a new referral order set. Currently, when you're referring to the Diabetes Center, you're going to use that referral paper that we've always had. You will either fax it and send it to the Diabetes Center. We call and schedule the person for an appointment. Starting on Friday, the 21st, that will be in the order set. You can go to that like you would any order and order a referral to the Diabetes Center. Please be careful that you do get the Mary Greeley Medical Center, Diabetes Center, rather than there is the Marshalltown order set in there. So make sure you've got the correct one. And also, this order set is not used for inpatient education. If you're wanting June to see somebody inpatient, that is a different order set. But that will be online. That will come to Patty, our receptionist, and she will call the individual and make that appointment. If that person doesn't want to schedule or doesn't show 2 times, she will let the referring person know about that. We do want to emphasize too, we've heard comments that coming to the Diabetes Center is a punishment for doing bad in controlling your diabetes. It is not a punishment. It is fun, and I believe that everybody with diabetes deserves the opportunity to have education and support in managing their diabetes. So please encourage them to come, that it is important. It isn't because they're doing a poor job. Okay, and this, I just put this up here, and there is a handout with that so that you can, and on the handout it does tell where to get that. The next one is the inpatient use of subcutaneous insulin infusion, that CSII pump document. It's available on the intranet now. We put that together so that there would not be as many problems with persons coming in with pumps. people that come into the hospital with pumps, there's a lot of gray areas. Who's going to manage the pump? Who's going to get supplies? How do we write down what that patient's getting for insulin? This document is going to take care of that, we hope. We have had a couple of instances where families have brought a member in with the pump and then left, and there was nobody to manage that pump. Because, as I said, we don't expect any of you to be experts in managing pumps. This document can be pulled off the internet, go over it with the patient and the family when they're admitted, have them sign it. In there it says that they are to manage their pump if they're not able to manage their pump, or have a family member there that can manage the pump, then they will be put on MDI or multiple daily injections, so that there's a total understanding before a problem arises. Also, they'll be responsible for bringing in their supplies, their reservoirs, and their tubing. They cannot bring in insulin. That needs to be ordered from the pharmacy. But all of that, go through that with them so that there's a clear understanding and we don't end up with difficulties and misunderstandings, such as a family leaving and then nobody knows how to give this person a bolus. Okay, let's get to the hands-on. And this also has a guide in it for keeping track of what insulin they're taking. The patient can keep track on here and give it to you, and have that each one for each day so that we know what they're taking. What we're going to do is I'm going to show you the different pumps that are available in the United States right now that we actually have. And we're going to actually hand out there's going to be 2 different pumps that we're going to have you use and learn how to give a bolus, learn how to look at the basal rates, and learn how to retrieve information that you may need in making an assessment on this patient. The first one I have here is the Accucheck Spirit. This one has just started to be shipped. They had an older version that did not have a meter that connected with it, but this one will have a meter. The blood glucose meter sends the blood sugar to the pump. The pump is programmed with those insulin to carb and correction factors as well as basal rates, and then it delivers that. The individual wearing a pump only needs to check their blood sugar, enter the amount of carbs, and the pump does all the calculation, and they push a button to take the bolus. It takes about 1 minute to do the entire process. 5 seconds to do a blood sugar, 10 seconds to calculate the carbs, and push the button and deliver. So it really is an easy way to manage. A different kind of delivery system is called the Omnipod, and this is what Dr. Carano was talking about. This is actually the pod that holds the insulin. It's a tubeless system, and the insulin is put in here, the pod is put on the arm or the abdomen, and then with the PDM, Personal Diabetes Manager, they are able to inject the cannula. The cannula and a needle is popped into the skin, the needle is retracted, and then that stays on there. They do a blood glucose on their meter, they enter their carbs, and with a push of a button, this meter tells the pump to deliver the insulin. The drawback with this one is that if you lose your PDM, you cannot give any insulin from the pod. There are pods coming out that have buttons on the side where a bolus can be delivered, and these pods are due to be about 1/3 smaller in the near future. So this is a tubeless system, which a lot of people really enjoy, not having that connection. The newest technology to come out is a touchpad phone. It's just like your smartphone, and it's just a matter of touching it, entering your carbs, entering the blood sugar, and then delivering the insulin. This one actually does not have a reservoir. A reservoir looks like a syringe. This one actually has a bladder type device, and this is changed each time they put new insulin in. These are all supposed to be changed every 2 to 3 days. And we have no one on this yet. We just got this one. The Animas system works a lot, and we're showing all the pumps. We don't give preference to any. When we show these to our patients, we show them all of them. We try to match them to the one that's going to work best for their needs and their capabilities. The Animas pump is a pump with a reservoir in it with insulin. It has the tubing, and it has a blood glucose meter. This works the same as the Omnipod in that they do the blood sugar on the meter, put in the carbohydrates, and they deliver the bolus with the meter. If they lose the meter, they are still able to do that on the insulin pump. And the one we're going to start with practicing on is the Medtronic Revel pump. And this device has a blood glucose meter, and they actually have 3 different blood glucose meters that connect with this pump. The blood sugar is done on the glucose meter. That is sent to the pump automatically, and then on the pump they enter the carbohydrates and it calculates the bolus. So the main thing that people have to know is not only how to manage the pump, but check their blood sugar, make sure they have an accurate reading, and put in carbohydrates. The pump is only as good as the information it's given. If we're guessing at blood sugars and we're guessing at carbohydrates, it's not going to improve control. And that's where people need the follow-up, the encouragement to know that they're using these devices appropriately. So what we're going to do, I'm going to have the girls pass out the pumps in just a minute. In order to do a bolus, I'm going to walk you through the steps, and then I'm going to have you calculate the carbohydrates you ate today. You have a blood sugar assignment on your card. So on this, the activate button is like the enter button. It's going to bring up a menu. The first thing on this menu is the bolus. In there, we're going to use the bolus wizard. You will enter your blood sugar, blood glucose. You will then calculate your carbs, and I will put up a slide with the carbs of the food that you ate today, and you will enter how many carbs you have. And this will then calculate how much you're to take. By then pushing activate again, it's going to give you a dose, and again, and it's going to deliver it. So those are the steps you're going to go through. I'm going to put up the card slide, and I'm going to have the girls pass out the pump so that you can do this. I say, does anybody want to move down, make sure that they get a pump? And I don't know if we'll have one for everyone, but we should be pretty close. Now you're assigned a blood sugar. You can't make one up. Okay, did you count your carbs? Okay. If you've counted your carbs up, press the activate button on the pump. Oh, not everybody's done. I won't put Elmo back on. Okay, press the activate button, and then it's going to say use bolus wizard. Bolus wizard is the term that this pump used for calculating. Okay, press activate, and then it'll say use bolus wizard, and then press activate again, and now enter your blood sugar, actually blood glucose. Yeah, your blood sugar's on your sheet that you were given. Once you've entered the blood sugar, press activate, which is just like pressing enter on your computer, and now enter the number of grams of carbohydrate that you ate for lunch. Once you have entered the carbohydrate grams that you ate for lunch today, press activate again. It will tell you what the estimated total is, and it will break it down for how much is for your blood sugar, how much is for your carbs. Press activate again, and once that number is blinking, press activate again and it will be delivered. Did everyone get a result and get the insulin delivered? Questions? Okay, once you've delivered a bolus, if your blood sugar is elevated, we usually ask people to check in 2 hours to make sure that the blood sugar comes down. But that's in the protocol for that we have the inpatient intensive insulin protocol. Any questions on boluses? Yes. Okay. Insurance coverage? Yes. Generally, if you have diabetes, most of them will cover. Medicare, private pay, Medicaid, for insulin pumps, we generally can get that covered. The amount of coverage is going to differ. Usually it's between 80 to 100%. And then that will run the same for their supplies throughout the year. Another thing that is playing a bigger part lately is deductible, as more people have a higher deductible. So there are more issues with complete coverage than there used to be, but generally we can get pumps for anyone. Okay? All right, the other thing we were going to look at was how to look at the basal rates, so that if you need to know what your patient is getting for a basal rate, press activate once, and on that main screen, arrow down until you see basal. Once you see the word basal, press activate again and arrow down to basal review. That is going to give you what the individual is getting throughout the day. Usually they will have 3 or 4 up to 12 different basal rates, but that will let you know what they're getting when. One thing to look for is if there are any zeros in that review. Sometimes patient will change their basal rate and eliminate a certain rate, and then there may be 2 or 3 hours where they're not getting any insulin. We adjust the basal rate based on their blood glucose patterns. We ask them to check 4 to 8 times a day, and based on those readings is how we adjust the basal rate. In time, we hope to have them be able to do that, but it does take considerable time of learning about pattern management. Did everybody get to the basal review? Okay, the other feature on here, if you'll press escape until you have the blank screen, escape is going backwards. From the main screen, if you press escape once, you're going to come to a status screen. That status screen is going to tell you everything that's going on right now with that insulin pump. It will tell you when the last bolus was given. It will tell you what the basal rate is right now. It will tell you when the reservoir was started, and it will tell you how many units are left in that reservoir. The reservoirs and the sites need to be changed about every 2 to 3 days. So you need to check that and make sure if they're in the hospital that that's getting changed. Did everyone get to the status screen? So just by those simple steps, you can find out how to assist your patient in giving a bolus, how to check their basal rate, and how to check what's going on right now. When a patient checks in, it's a good idea to ask them how their pump is put into suspend. So if you would need to stop that pump for any reason, if they were having a low blood sugar, you would be able to assist them with that. As you know, with low blood sugars, they're not able to always respond like they should or really know what they need to do. Questions on the Medtronic pump? Okay, when they go to X-ray, CT scan, or MRI, they should take their pump off. When you take a pump off, make sure that you're disconnecting it at the site. Don't take the reservoir out of the pump. They shouldn't be off of it any more than an hour. They should check it when they remove it and when they restart it. So make sure. We had some people go to for an MRI and it was left on. It can cause a malfunction in the pump. So make sure those are getting removed at those times. Any questions? Like I said, you're not going to be an expert, but do you feel like if you had somebody come in with it, you could at least find the information, be able to document what they're getting? Okay, the question was, what are the major problems like kinking of the tubes? The tubing on these are a double lumen tube, and I didn't bring down my tubing that has the break in it. I have tied these into a knot and pulled it as hard as I could and delivered a bolus, and it did not kink. It's very, very difficult to do that. Sometimes it looks like they're kinked because with the double lumen, when these get pinched, it'll make a mark in there. And how we have people check to make sure there's not a blockage in there is disconnect from their site, put in a small bolus, and deliver it. If that mark doesn't move on the tubing, then it's not a problem. But it's very, very, very difficult to do that. Do they ever give the wrong dose? Some patients will. They will override what the pump says to give. They will either move it back and take less, or they'll increase it. No, the pump is going to deliver based on the information given. So the blood glucose and the carbs, and then the settings that are in there. The settings might be incorrect, as if, if they're in the hospital, maybe their correction factor needs to be a little higher than it was when they weren't hospitalized. So it could be the settings aren't quite right, but there again, that's why we look at the total daily dose, we look at their blood glucose patterns, and we try to make adjustments probably a little more often in the hospital. And that's where Dr. Carano, Dr. Amakaya, June can be a great asset in helping with that. Most of the people, we hope, that have pumps are able to see what's happening and know what they need to do. Oh, any malfunctions that would cause too much delivery? There's always that possibility. Well, the X-ray, yeah. Yeah, because we said that. Yeah. There can be, it can malfunction. Usually, though, what we see is there's going to be a delivery problem where it'll just stop delivery. Is what? Yeah, I was going to say most often the problem is that it will stop delivery and not deliver the whole bolus. And then we have to do some problem solving, whether it's a site issue or a pump issue. But yeah, it still is just a delivery device, and it can malfunction. Have not seen that. The only time I think they saw that was years ago when they first started. Actually, a physician had an insulin pump on and went up in an airplane and with air pressure actually delivered a whole reservoir of insulin. But that's been 20 years ago. And I haven't heard of that since. Any other questions? Yes? Yes, they are waterproof. You can leave it attached. Or no, the Medtronic, I'm sorry, is water resistant. It's not. Some of them are. This one you would disconnect at the site, lay your pump on the counter, go shower, come back and reconnect. There are the Animas you can go swimming with. The Omnipod you can go swimming with. Those are waterproof, but the Medtronic is not. Any other questions? Do we want to try the Animas pump? And I said that about the cartridge. Yeah, don't take the cartridge out just to disconnect. Disconnect from the site. If they're putting in a new reservoir and a new site, you want to always make sure they're disconnected, that they're not priming with that connected. But that's probably something that they're going to be able to do. If they can't do that themselves, they shouldn't be managing it in the hospital. I have had a couple of patients choose to go off the pump. Those reasons were they didn't want to be attached to something. That's become less of a problem now that we have the tubeless pumps. And there have been some where I had one individual who just had so much scar tissue that they wanted to go back to multiple daily injections just because they couldn't find sites for the pump. But not very often anymore. Any other questions? Concerns? Do you know where to go to get help? And I guess if we want to try the Animas, we can do that. If anybody wants to try a different one, or if you need to get back. Oh, yes, and there's an 800 number on the back of all the pumps if there are any questions. So there's always the company that's available that you can call. Okay, thank you for coming. And if you have any questions, let us know.